Hello everyone, this is DrBarai. I'm a consultant in emergency medicine. Over the next half an hour or so, we are going to talk about how to measure LVOT VTI, or left ventricular outflow tract velocity time integral. This is a step-by-step approach that you can use for the assessment and management of your critically ill patients. I hope that you find this video useful. If you have got any questions or if you don't understand any particular step, please write in the comment section and I will get back to you as soon as I can. So, why do we care about left ventricular outflow tract velocity time integral? Why should we use it in our day-to-day practice? First of all, LVOT VTI helps to estimate the cardiac output, and that is exactly the amount of blood that is pumped from the left ventricle to the rest of the body, especially the vital organs, the heart, the brain, the kidneys, intestines, the liver. If we know exactly what the cardiac output is, then we can understand if the person is doing well or needs some help and support. This is a non-invasive procedure that we can use on the bedside with a portable device. So I find it very useful in my day-to-day practice. In addition to that, it is super important in the critically ill patient, especially with those who have got hypotension or shock, heart failure or heart valve disease. It's like in the cars, if I ask you how many miles per gallon the car drives, LVOT VTI is the number that will tell you how far this heart is pumping blood to. The normal value of the LVOT VTI is 18 centimeter to 22 centimeter. What it necessarily means is that every time the left ventricle contracts, the blood is pumped for 18 to 22 centimeter. The further is the distance the blood can be pumped from the left ventricle, the better is the efficiency of the left ventricle. Think of the LVOT VTI like the distance of a drop of blood that travels every time the heart beats. Obviously, if there is some pathology in the heart, like a heart attack or a cardiac tamponade, or if the patient is in a shock or is in heart failure, this distance that the blood is pumped will be reduced. So let's get into the basic. Let's get into the fundamentals of the left ventricular outflow tract velocity time integral, or LVOT VTI. We talked about it. So LVOT VTI is the distance in centimeters that the blood travels during every cardiac cycle. We measure it in centimeters for conventional reasons. All the research papers that you will come across, you will find that the LVOT VTI is in centimeters. We use a very clever technique called the pulsed wave Doppler, by which you can focus on a specific area of the left ventricular outflow tract and measure exactly how far that particular blood is traveling to. If we know the LVOT diameter, we can measure the stroke volume. I'll give you some calculations and it is super easy to calculate. So this is the formula. Stroke volume is equal to the left ventricular outflow tract area multiplied by LVOT VTI. The assumption here is that the left ventricular outflow tract is like a cylinder. So if we know the height of the cylinder and the diameter or the radius of the cylinder, we can measure the stroke volume. I'll show you some further animations and some beautiful clips to illustrate this even further. So here we go. So this is the parasternal long axis view. As you can see, this is the right ventricular outflow tract. This is the interventricular septum. We have got the left ventricle here, Then this is the mitral valve, the anterior leaflet and the posterior leaflet. The left atrium is here, the descending thoracic aorta is here, and of course that's the aortic valve, and this is the ascending aorta. This area is called the left ventricular outflow tract, and as you can see, it seems to be like a cylinder. Of course, every person is different, everybody's heart is different, the shape of the left ventricular outflow tract may be different. However, to keep it simple, we can assume that the left ventricular outflow tract is like a cylinder, just like this guy here. And as you can see that every time this left ventricle is contracting, that cylinder of blood is pumping through the aortic valve to the ascending aorta. So if this is the cylinder, it has got two dimensions. One is that it has got a height or length of the cylinder, that is the VTI, LVOT VTI, and the area of the cylinder. So let's illustrate here on the side of the slide. So this is our cylinder. As you can see, the VTI or the height of the cylinder is here, and the area of the cylinder is calculated by some calculations that I am going to show you now. So in the cylinder area here, which is the area of the LVOT, we have got a diameter which is from this end to this end, and that is the distance here. Half of the diameter is the radius. If we multiply the r square with pi, then we get the area of the cylinder. And if we multiply that area with the height, that is the LVOT VTI, we get the volume of the cylinder, which is the stroke volume. Let me keep it very simple. Most people have got the LVOT diameter as 2 centimeter. So LVOT diameter is 2 centimeter divided by 2 to get the radius, which is 2 divided by 2 is 1. 1 square is 1. So essentially the area of the cylinder is the value of the pi, which is 3.14. So most people have got the area of the cylinder as 3.14 square centimeter. So if we know what the VTI is, then we can easily calculate the stroke volume. Let me give you an example. For example, a fit and healthy person like this patient has got a VTI, LVOT VTI of 20 centimeter. So if the LVOT diameter is 2 centimeter, we know that the volume is pi multiplied by the LVOT VTI, which is 20 centimeter, and the pi value is 3.14 centimeter. Essentially 3.14 multiplied by 20, which is 62.8 ml, is the stroke volume. So you don't have to even measure the LVOT diameter. Of course, as I've said, everybody is different. To be precise and to be accurate, we must do the LVOT diameter measurement. But if we don't have the time, and we can assume that it is 2 centimeter, by looking at the LVOT VTI, we can assume what the stroke volume might be. In my day-to-day practice, I find that if I get the LVOT VTI, I use the LVOT VTI as a serial measurement. What I meant is, I do the LVOT VTI, give some treatment like IV fluid or some inotropic support. I measure the LVOT VTI again, and half an hour later again, and I see if my treatment or intervention is actually working or not. So I use the LVOT VTI not as a static number, but as a dynamic number, and I use it for the assessment of the responsiveness of the patient to the treatment that I am giving. It is very important to understand that LVOT VTI is not a static number, it's a dynamic number, and we must use it again and again in the same patient to identify if there is any responsiveness to the treatment. So the next step, of course, is the measurement step, how we are going to measure the LVOT VTI. So this is the heart, as you can see. To get oriented with this animation, this is the right atrium, tricuspid valve, right ventricle. This is the left ventricle here, left atrium is here, and this is the mitral valve. This is the aortic valve. So when we do the echocardiography, of course, the heart is flipped upside down, right and left, they are flipped as well. So once again, that's the interventricular septum, vertically oriented. This is the left ventricle, this is the mitral valve, this is the left atrium, and this is the aortic valve, and there is the ascending aorta. And this area is the left ventricular outflow tract. So let me show you how it is measured in real life. So that's my phased array probe, and we have got the pulse wave Doppler signal, and as you can see that I am applying the signal exactly just below the aortic valve in the left ventricular outflow tract. And once we press on the buttons to identify if we can get the LVOT VTI, it will look like this. So every time there is blood flowing through the aortic valve or left ventricular outflow tract, we will get this type of waves. What it necessarily means is that the blood is going away from the probe. That is why it is negative, it is going down. The next what we need to do is we are going to press on the freeze button, and then in the ultrasound machine we have got the finger painting and tracing device, and we can trace from here all the way to the bottom and then go up and finish it here. Now most people who have got this no valvular disease, they will have a vertical line here, which means that the aortic valve is closing. So if we trace the wave form, then the machine will do the calculations and it will give us a number which may be 18, 20, 22, below 18 or above 22 centimeter. So this is how it is measured. Let me show you a real life patient so that you can understand this even better. So this was a 68-year-old lady that I saw a few months ago. She came with chest pain and shortness of breath. So we have got a lot of differentials in my head, but at that point what I did is I did a apical 5-chamber view, and this is the apical 5-chamber view, as you can see. So this is the right ventricle, the left ventricle, the right atrium, left atrium, interventricular septum here, and this is the interatrial septum. This is not the textbook type of apical 5-chamber view, but if you carefully look at it as the patient was breathing in and out, we can have some view of the aortic valve which is here. So this area is the left ventricular outflow tract. So what I did is I have started on the pulse wave Doppler, and I used the signal just below the aortic valve, and I got these waveforms. As you can see that just after the wave there is a vertical line, that means the aortic valve is closing. With the finger painting we can trace the edge or the margin of this waveform, and once we do that the machine can calculate what the LVOT VTI is. In this particular patient the LVOT VTI is 14.4 centimeter, well below the baseline. As I mentioned, the normal LVOT VTI is 18 to 22 centimeter. So here we have got 14.4 centimeter. Is it important? Of course it is important, because this person is telling us that the left ventricular contraction effectiveness is not that great. So in this patient the stroke volume is LVOT VTI multiplied by the area of the cylinder, which is pi, which is 3.14 centimeter. So it will be around how much? 3 multiplied by 14. So we have got 42 ml, which is not that great. Normal stroke volume is 60 to 80 ml. So this is well below normal. I feel that in this particular patient, the VTI was important because we started on thrombolysis. There was increased troponin. The CTPA shows that there is large P, and it was a small rural hospital where we do not have the respiratory department. We did not have the facility for clot retrieval. So after talking to the respiratory department, we started on thrombolysis. After the thrombolysis, I measured the VTI again, and it improved to 18 centimeter, which is normal. What it necessarily means is that the thrombolysis was effective. As the obstruction of the pulmonary artery is reduced after thrombolysis, the effectiveness of the left ventricular contraction improved significantly. And that is where the LVOT VTI is so important. It helps us to assess if the treatment is actually working or not. So let's recap what we have talked about so far. So what is LVOT VTI? This is the distance that the blood travels during every left ventricular contraction. We use a Doppler technique, and the formula that we are using is stroke volume multiplied by heart rate is the cardiac output. The stroke volume is LVOT area multiplied by LVOT VTI. If we know the LVOT VTI, it gives us some rough idea about the stroke volume and the cardiac output. So I have already shown you the animations. Let's get into further details. The very first step is measurement of the LVOT diameter. The second step is to get the apical 5-chamber view, and then we will start on the pulsed wave Doppler and then trace the VTI. I'm sorry about the mistake here, it should be pulsed wave Doppler. So this is the very first step, get your LVOT diameter. So this is the one measurement, rule them all, because if it is wrong, then the actual number of the stroke volume will be different. So first thing first, we will get a parasternal long axis view. Then we will zoom in into the aortic valve area. Then from inner edge to inner edge, we at the mid systole, we will calculate the distance, and that is the LVOT diameter. Normal LVOT diameter is 1.8 centimeter to 2.2 centimeter. Let me show you some animations so that you understand. If you still have got any questions, please write in the comment section and we can get back to you as soon as we can. So it's very important that we get the actual mid diastolic phase of the left ventricular outflow tract. So what we can do is we can fridge the image and then we can go forward and backward to find out exactly where the valve opens and the annulus is visible. So this is again the same picture that I have shown you earlier. This is the interventricular septum. This is the left ventricular outflow tract. We have the right ventricle here, left ventricle here. The aortic valve is here. As you can see, the aortic valve annulus is here. Ascending aorta is here. Left atrium is here. Now this is the anterior leaflet of the mitral valve, and this is the interventricular septum. At the mid systole, when the aortic valve is open and the anterior leaflet of the mitral valve is almost parallel to the interventricular septum, this is exactly when we should measure the left ventricular outflow tract diameter, and it should be done inner edge to inner edge. Most people have got the LVOT diameter of 2 centimeter, but please don't rely on that number because everybody is different, especially the elderly people who might have a calcified aortic valve. Some people may have the very thick interventricular septum. In case of HOCM, for example, they will have very narrow left ventricular outflow tract VTI, left ventricular outflow tract diameter. The second step is to get a very good apical 5-chamber view. So the first thing in this case is that we need to get a very good apical 4-chamber view, And then if we tilt the probe a little bit, we might find a beautiful apical 5-chamber view. Once we get the apical 5-chamber view, we identify the aortic valve and the left ventricular outflow tract. And in my animations and the clips, I have shown you this already. Now, this is very important that the Doppler beam is parallel to the LVOT. If it is angled more than 20 degrees, you might get a wrong value. Some of the ultrasound machines, they can have the ability to manually steer the ultrasound beam so that it is parallel, the Doppler beam is parallel to the flow of the left ventricular outflow tract. So this is a beautiful clip that I can show you. This is the apical 5-chamber view. As you can see, this is the right ventricle here, left ventricle is here. This is the aortic valve. As you can see, the aortic valve annulus is here and the cusps are here. There is a bit of rotation of the probe, that's why we cannot see the right and left atria very well. We cannot see the tricuspid valve and the mitral valve very well either. So this area is the left ventricular outflow tract and this is the aortic valve. So what we need to do is we use the pulse wave Doppler and use the signal just over here, just below the aortic valve. So the next step is that we catch the flow. So we place the sample gate just below the aortic valve and the gate size is usually 3 to 5 millimeter and we get some clean symmetrical waveform. Now when you do this step, you should be aiming for some bullet shaped waveforms, not some fireworks mess. Most ultrasound machines that we use at this stage will give you some sound as well as these waveforms are developed. So this is a good example. As you can see, apical 5-chamber view, this is the signal gate here just below the aortic valve and we have got these beautiful waveforms. They look like bullets and we need to use the finger painting technique to check or to identify the tracing of the edge of these bullets. So we start from here and then we go all the way to the bottom and then we finish it here. Once we do that, the machine will do all the calculations and it will give you the exact VTI. In my practice, I do not rely on one measurement. I always repeat at least 2-3 times and I take an average of it. So I might get 18, 18.5 and 19. Then on an average it is 18.5, which is my LVOT VTI. So this is the tracing. We can use the tracing tool. Most ultrasound machines have got the LVOT VTI tracing tool and the machine can do the calculations. And as I've said, do not rely on one number. LVOT VTI is not a static number. It can vary from bit to bit. It can vary from time to time. So always do at least 3 or 5 bits and it will give you a rough idea about exactly what the VTI is. Now in this patient, we did only one tracing and the machine gave the number 17.5 centimeter. So what it necessarily means is when the left ventricle is contracting, the blood from here is flowing through the aortic valve for 17.5 centimeter, which is almost normal. The normal value is 18 to 22 centimeter. So let me give you one example. So this patient came with shortness of breath and we have measured the left ventricular outflow tract diameter in the parasternal long axis view. It's 2 centimeter. So the radius is 2 divided by 2, that is 1 centimeter. Pi multiplied by r square is actually the pi, which is 3.14 square centimeter. So that's the area of the cylinder. All we need to do is now get the LVOT VTI. In this patient, we did 3 calculations or 3 measurements and we found that the average is 20 centimeter. So if the VTI is 20 centimeter, it means that when the left ventricle contracts, the blood flows for 20 centimeter every time the left ventricle is contracting. Because the area is 3.14 centimeter, the volume, the stroke volume is 3.14 multiplied by 20, which is 62.8 ml. Not bad. It's pretty good because the normal stroke volume is 60 to 80 ml. Now, if you look at the heart rate of this person, say the heart rate is 70 beats per minute. So 62 multiplied by 70, which is about 4.3 liter. 4.3 liter is not very good, but again it is not that bad either. So what it necessarily means is that we have measured the LVOT VTI in a patient coming with shortness of breath. We have got a lot of differentials in our mind. If we give any treatment, for example, if we suspect this person has got pneumonia and we have given some fluid, we have given some antibiotics, and then we check the LVOT VTI again, we may find that the VTI has improved to 65 ml, which is great. So this is the main advantage of the LVOT VTI, that we can do it multiple times and we can check if our treatment is actually making any difference to the patient. So let's share some tips with you. First of all, the colored Doppler can be used at first to identify exactly where the left ventricular outflow tract is in the apical 5-chamber view. Avoid measuring during the ectopic beats and tachycardia. This is a big challenge for me to measure the LVOT VTI in patients with atrial fibrillation, for example, because every beat will be different, and if they come, sometimes they are very fast and it can be quite a bit of a challenge. However, if we really need to measure the LVOT VTI in this type of patients with ectopic beats or tachycardia, my suggestion is do it 3 to 5 times and then get an average of it. I have got a separate video where I talked about the various pitfalls of the LVOT VTI. To summarize that, a couple of things that I am going to focus on. First of all, the Doppler angle needs to be less than 20 degrees from the flow. If it is more than 20 degrees, it will give you a wrong VTI, probably a low VTI than actual number. If we measure in the wrong spot, for example, if the signal gate is too distal or too close to the aortic valve, we will get wrong numbers. If the tracing is bad, then it will also give you wrong values. So you need to be super cool in finger painting, finger tracing. Most of us use the left index finger to do the finger tracing. Some people use the right finger. I don't care whether using right hand or left hand. As long as the tracing is good, it will give you the good value. To compensate that technical error, again my suggestion is do it again and again and again. If you do 3 to 5 measurements and then do an average value, that will give you a more appropriate number than considering only one value. So keep it clean, keep it straight, and keep it central. That's the advice I can give you. Alright, so let's summarize everything. The first thing first, we need to get a parasternal long axis view to get the LVOT diameter from inner edge to inner edge. Then we get an apical 4-chamber view and convert it to apical 5-chamber view. And just below the and I will place the signal gate just below the valve, which is towards the apex, towards the probe. And then we trace the waveform, and the machine will do the hard work. Machine will give you a number. And use the formula that stroke volume is equal to area multiplied by VTI. So if we consider a cylinder, the area multiplied by the height, which is the VTI, will give us the stroke volume. It is so simple. So in real life, we can use this LVOT VTI for a number of reasons, especially to identify the hypovolemia in a critically ill patients. How it works. So if we know that this person is otherwise well, and we check the VTI and we find that the VTI is lower than 18 centimeter, the first thing that will strike our mind is that there is possibly hypovolemia. We can monitor the fluid responsiveness. It has happened so many times in my patients that I check the VTI, I gave some fluid, check the VTI again, and we find that the VTI has improved significantly. Great, this person is responding to the fluid, give some more. If the fluid responsiveness does not work, if I find that LVOT VTI has not changed even after giving fluid, we will think about something else. We may give some inotropes, for example. In case of the valvular heart disease, the severity can be detected with this LVOT VTI. If you have any questions, please write in the comment section and I'll get back to you as soon as I can. Thank you very much for taking your time. It was a great pleasure seeing you all, and we will get in touch again with further queries. And I've got few more videos on this topic, and I hope that I will see you soon. Once again, if you have got any questions, please don't hesitate to write in the comment section. And if you have not subscribed already, please subscribe to the channel. We have got a lot more videos on this topic and various more exciting topics on echocardiography, ECG, radiology, and emergency medicine as a whole are coming up. Thank you very much. Bye for now.
Do you want to learn more about LVOT VTI? Get in touch. See you later.
Please subscribe to the channel and press on the bell notification. Any questions, write in comment section below.